Professor Sangeda.
Hello. Okay, thank you, MC, for thank you, MC, for bringing us to the next session. Ladies and gentlemen, good afternoon. We are now going to be into our scientific session of this symposium, Advancing the Fight Against Antimicrobial Resistance in Tanzania, a One Health update on progress, gaps, and the road ahead. In the next talk, I would like to introduce the keynote speaker, Professor Mek Mate from MUHAS. And I would like to take this opportunity to give you a short bio of Professor Mek Mate, who is a professor of microbiology and immunology at Muhimbili University of Health and Allied Sciences, MUHAS. He's one of the stabilizing pioneer of antimicrobial resistance surveillance in Tanzania and leader of the SACID One Health AMR research group. He's a foremost advocate of the One Health approach, champion of the vital integration of human, animal, and environmental section to effectively control and contain antimicrobial resistance. His research footprint is extensive and prolific, with so many publications focusing on antimicrobial resistance dynamics across adverse ecosystems, including hospitals, livestock, poultry, and local communities. And this is evident from global ranking statistics, which shows him as one of the leading scientists in Tanzania. So without further ado, I hope you are all set, the setup. Okay. So I'll still finish the remaining paragraph. On a broader scale, Professor Mate has driven systemic capacity building in leading Fleming funding supported programs, which aimed at strengthening antimicrobial surveillance infrastructure while simultaneously contributing his expertise to Africa CDC antimicrobial resistance policy initiatives. Beyond his research and policy milestones, he has profoundly shaped the future of global health by mentoring generations of Tanzanian antimicrobial resistance scientists, some of whom are sitting here right now. So Professor Mate will give us a keynote speech on the state of antimicrobial resistance, current challenges, opportunities, and the path forward for global and local landscape. Please give a hand of applause to Professor Mek Isaac Mate.
Thank you. Can you hear me? I would like to thank the University of MUHAS for inviting me to be a keynote speaker. I think this is the third year in a row that I'm giving a keynote address on the important topic of antimicrobial resistance. During our time as medical students, the term antimicrobial resistance was non-existent. But thanks to the behavior of people, this is now a global threat. Okay? Unlike human beings or animals, bacteria, pathogens actually share a lot. They share gifts in terms of transposons, plasmids, and genes, which gives them the ability to resist agents that are intended to either inhibit or kill them. So today my talk is, I'm going to give you a synthesis of a global synthesis, and then African, and then go down to Tanzania. Next slide. So, globally, it is estimated that about 5 million people die because of AMR-associated illnesses. There is a difference between direct death from AMR and associated. Do you know the difference? If a patient has got cancer and develops a resistant infection, that is associated. It is not a direct. It is projected that if we don't take measures, by 2050, almost 50 million people will be dying every year if the trend continues. And in terms of hospital expenditure globally, about 400 billion US dollars, not T shillings, will be spent on cost, increase hospitalization, medication, etc. There will be a significant loss of productivity, which is estimated to be around 4% reduction in GDP. Next slide, please. In response to the potential threat, the global community came up with issues. The GLASS, this is a surveillance program that is intended to monitor trends and pattern of antimicrobial resistance. Recognition that this is a One Health. This has been a tremendous recognition. Initially, science was confined to humans, leaving aside vet, and more importantly, the environment. The environment is an important conduit of antimicrobial resistance in terms that it is a reservoir, but also a transmitter, a conduit. And then there are issues of stewardship, controlled use of antibiotics or antimicrobials in a way that limits irrational use. And then we, as scientists, including MUAS, we're embarking on research and innovation. And the current trend nowadays is to move away from the antibiotics to alternative therapies like bacteriophages, viruses which can attack bacteria, or specific immunoglobulins that are targeting pathogens. And then we have the national action plans. The national action plans these are plans that coordinate stakeholders at the national level down to the bottom to make sure that all sectors are united and combine effectively towards combating this. Now, why is AMR important in sub-Saharan Africa? My colleague, Dr. Zura Kimera, I think we are writing a paper on why sub-Saharan Africa is disproportionately affected by this problem. Yeah? About 250 deaths are directly attributed to antimicrobial resistance, and about 1 million, they are associated. Remember the difference I said? So, in a mathematical terms, the mortality that occurs in Africa, sub-Saharan Africa, is 20% of the global total. Okay? So this actually is a threat to development programs. Okay? It is projected that if things continue like this, antimicrobial resistance will be by far the most leading cause of death, morbidity, mortality, and hospital associated costs. So, what are the drivers? Because we talked about the magnitude, but what are the drivers? Sub-Saharan Africa, unfortunately, has got the highest burden of disease, infectious diseases. Yeah? malaria. Most of the malaria occurs here, but also bacterial, fungal infections, okay? HIV, 70% of HIV infection occurs in this area. So that is one point, heavy disease pattern. And then this is coupled with limited access to diagnostics. Yeah. Actually, it is estimated that, and this is an optimistic figure, that about less than 10% of patients have got access to culture and sensitivity facilities. And I'm sure, I mean, the figure is very, very optimistic. And up to half of the antibiotics are given inappropriately. Of course, because if you have limited diagnostics, then and it is a pity, because if we have so much infection in Africa, and we are producing a lot of data, for instance, at Muhimbili, we have a lot of data, isn't it? In terms of resistance. Why can't we use that data to develop antibiograms to be able to predict it? I mean, if you get a patient, if without facilities, more likely I can give this medication with, okay? And then we have weak IPC in health facilities. Actually, up to 20% of inpatients acquire hospital-acquired infections. And as you know, these are not community-acquired infections. By definition, they are much more resistant to infection, to common medicines than otherwise. And then we have poor wash. Yeah. It is estimated that in sub-Saharan Africa, more than 400 million people do not have sufficient sanitation, hygiene, and water. And then this is coupled with weak surveillance, in which case I was listening to the guest of honor with a lot of attention, but I want to tell you that less than 50% of African countries have got a fully functional surveillance system. Next slide. So what is the take-home message from the slides that I talked about sub-Saharan Africa? Is that sub-Saharan Africa by far carries the most burden of AMR, with millions affected. And this is really becoming a threat to systems, economies, and development. Okay? Next slide. So back home, what do we have? AMR is a big problem here too. Yeah? Actually, in 2019, it was estimated that about 12,500 deaths were directly due to, attributed due to resistance. And about 54 million were linked. A person has got a different condition and is infected with antimicrobial resistant organisms. So, okay. So, can you hear me now? So Tanzania is one of the of African countries, East African countries, that has got a lot of antimicrobial. And it took us quite a long time to understand that this is a One Health issue. As I said, pathogens have got more collaboration among them than us. Yeah, they share gifts, as I said, gifts in terms of genes, small and big ones. And these genes, they confer resistance. Bacteria becomes resistant by various mechanisms. They can pump out the drug. They can metabolize by using enzymes. They can alter the binding structure, etc., etc. And then gram-negative bacteria are more resistant to medications as compared to gram-positive. The structure of gram-negative bacteria is that they've got double membranes, which makes penetration of agents difficult. But also between the membranes, there is a periplasmic space, which contains a lot of enzymes. So, studies that our department has done, and Bugando, Kwas, Mbeya, etc., looking for resistant bacteria, they've come up with a picture that among isolates, about 40 to 70%, no, please go back. About 40 to 70% are resistant. Yeah, and for instance, ESBL producing enterobacterial. Yeah, and when you're talking of resistance, actually you can talk of monoresistance. You can talk of MDR, in which case a pathogen is more resistant to at least 3. And then you can talk of pan-resistance, in which, so in our case, we see a lot of ESBL, we see MRSA, we see multi-drug-resistant Klebsiella pneumonia, and we see carbapenem-resistant gram-negative bacteria. All of these bacteria are recognized by WHO as being priority pathogens because they're very difficult to treat, and then they're associated with significant mortality. Next slide. So what are the key drivers in our case? And I'm glad Lillian and Upendo went through the slides to make them better. There was a study that was done here in Muhimbili. It found that among patients who were in the ward, about 47% were on antibiotics. And a study that was conducted by Seni, you're here. If I misuse your data, please. You conducted a study in 6 referral hospitals, correct? And what you found is that antibiotic use is much higher, 62%. And you see, there's a tendency, at least when I was a medical student, that there are kind of medications that only the top doctors can prescribe. And polypharmacy was not unusual. So some patients, 52% of the patients, had more than one antibiotic. Okay? So as you can see, this is a recipe for selection pressure. You have high levels of resistance because of heavy use. You have high levels of resistance among isolates from the hospital. Next slide. So, among other things, over the counter, this is very common. People go to the pharmacy to buy medications, isn't it? Without prescriptions, yeah? And that is quite a lot. It's almost 100%. Yeah? So, and then others request, and unfortunately, some of them do not finish the dose. So in addition to having some of the medications as counterfeit, but there is also misuse of the. Next slide. Limited diagnostics. We mentioned about that. Just to put data on that, is that only 5% of microbiology perform cultures, and that is mainly limited to a few referral hospitals. Of those tested, results are only available for a fraction. Patients do not want to come back because of many reasons. Okay. Saying again, your 6 referral hospitals, you found that only 2 in 600 patients was treatment based on culture and sensitivity. Am I saying correct thing? Okay, I'm glad. So the bottom line is that almost 95% of medications are given without laboratory data. Next slide. And then there is weak stewardship, which is actually related to what I said. So you will be surprised that most of our physicians, me included, about a third, this is a study that was done by Hall, that about a third, only a third were familiar with proper use of medication. So what it says is that we are a problem in this problem. Okay, so about 1/3 of the prescriptions had no documentation. There's, as I said, high use of broad spectrum. If you want to be seen, if you want to be seen as a good doctor, you have to prescribe very strong drugs. And escalation, this de-escalation from IV to oral is very limited. Next slide. And this is an area where this is an area which has been really neglected. And I think Sangeda will. If you can't hear me, please. So there was a student whom I supervised, named Ganga Seguni. She did look for resistant bacteria in sewage here at MNH. And she followed that drain up to the Indian Ocean. And as you can see, I don't want to go through, the MDR pathogens in the environment are quite a lot. And there's international implication because this is draining towards the Indian Ocean, okay? So another study which was conducted in Tanzania, in Arusha, found that almost half of E. coli had a resistance to more than one drug. So what this slide means, if you forget everything, the environment is an important source of drug-resistant pathogens, and it acts as a conduit to transfer to either humans or animals, and it should be given equal weight. I'm glad that Zuhura, she's from an environmental background, she has been working on this. Poverty and climate change. These are, I mean, if you talk of poverty, you're talking of many things, and being unable to afford medication, complete dose. Yeah. It is estimated that 26% of us live below poverty line. I don't know what is the poverty line in terms of shillings here. I leave it to you. And then climate change. As I said, pathogens tend to change in order to survive in the environment. So if there are changes in temperature, for instance, they will adapt by making mutations that will make them resilient to the changing climate. Next slide. We have a lot of good plans, and in this country, I've been lucky to be associated with national action plans for antimicrobial resistance as a stakeholder. We are now in the second program, senior 2023, 2028, isn't it? Okay, we have costed very detailed budgeted of activities. But the problem is funding. I don't think if the government, I need to be corrected because members of the MCC are here, the contribution of the government towards these programs is less than 10%. Most of these activities are financed by donors who might have their own agenda. Yeah, maybe they want to test drugs here. They don't want. So it is not a health system strengthening strategy, as it is intended to be in solving antimicrobial resistance an issue. It's about 10%. 10% of the budget is covered by governments. I think, should I go? This is a summary of what I've been talking. Do I need to go? Or we can skip? Skip, please. We have had a number of students here whom we have supervised. They found, I cannot see there, but they found a lot of antibiotics in fish, in eggs, in chicken, in milk, vegetables. Each of these, what you are seeing here, is a student whom we supervise in the department. So we are talking in capital letters of what we are. And recently, we also found a lot of ARVs. When we published this paper, we were almost kicked. Next slide. So we have talked about the burden, the drivers. So what are the consequences? Globally, it is estimated that AMR could reduce to about $1 to $2 trillion by 2050. Tanzania, we don't have enough data, but it definitely increases the duration of stay. It involves switching to more expensive and toxic drugs, which have also shown resistance. Okay. I think that is, next slide. This is also related that nearly half of isolates from wound infections, they contain WHO priority pathogens, which I mentioned, yeah? And this actually threatens maternal and child health services, like cesarean section, pneumonia, cancer, okay? Next slide. So this, as I said, was the government's response. This is the second National Action Plan, which covers between 2023 and 2028. And it has got 6 objectives: to strengthen governance and coordination, to improve awareness and education, to strengthen surveillance and research, to reduce infections through IPC, to optimize use of antimicrobials in humans and animals, and to ensure sustainable financing. I leave it to you to think about the level of commitment that we are putting into this. We have a very good plan that is costed, but I don't know how much it is being financed. Next. So there is donor dependence. There's uneven implementation of activities across regions and across levels of service delivery. I'm sure in the dispensaries and the lower facilities, most of what we are talking about in terms of containment of AMR is none of the above, non-existent. There is inadequate monitoring, so we don't have a systematic way of collecting data to be able to monitor trends and patterns. And whenever we do intervention, it is not, we don't monitor how successful we are. And again, issues of stewardship. Next slide. This is the same, that we are donor dependent in many activities. I don't need to go into this because you have them. So this is something that we have to discuss. It is not about the slide. From the discussion that we have had, what do you think are the priority research areas for us as MUAS to contribute towards? Any ideas? Lillian. This is interactive. Anyone with first of all, we must have good surveillance data, sindio? So that we know the problem. Yeah, we have this magnitude of the problem, and we have so the pattern and magnitude. The second thing is to to implement measures. We have seen quite a lot of things that are not happening properly. Those need to be put into place. Okay? And then, as I said, we have to think out of the box to go outside the antibiotics and the conventional medications that we have now. There are quite a lot of investigations that, and then we have to use AI. So, as I said, you are doing a lot of culture and sensitivity results, for instance, in facilities. You're producing a lot of data, very useful data, but it is not being used. In the Western countries, this data is also treated with AI algorithms to be able to predict the most useful. Next slide. So our role as MOAS is to generate research, to generate evidence, population level surveillance, and this is a One Health issue, human, animals, and environment. To do genomic research. This is key. Many laboratories now don't rely on phenotypics because of the limited significance of such results. If you want to know how rhizostomes flow between compartments, human, animals, and environment, whole genome sequencing is key. The problem is that it is very expensive, okay? And then you have health systems and policy research, yeah? We have to create information that will inform the National Action Plan. We have to improve diagnostics. The key here is to have rapid diagnostics which can provide the results in a short period of time, but that, and then training and capacity building. As I said, most of the slides that I was showing here are from our MSc PhD students, which is nice. And then we have to mobilize funding. Unfortunately, the government does not give us substantial amount of funding. Therefore, we have to compete globally with a little that is available. And I would like to encourage people, groups, for the current UK NHIR call, we should apply. So what will be the expected outcomes? Strengthen the AMR knowledge, identification of national priorities, capacity building, partnerships, and commitment to action. We are talking a lot, but it's only a fraction of which is put into action. Next slide. So in closing my long talk is that we as a Tanzanian leading health science university, we play a vital role in generating evidence, training AMR workforce, strengthening laboratory capacity, inform policy in order to reduce antimicrobial resistance through a One Health approach. Thank you very much.
So thank you very much, Professor Mate, for a very enlightening talk. You have covered a lot, and you have sent home your key message, which will help us to move forward in the fight against antimicrobial resistance. You have highlighted how limited we are towards universal health coverage and the Sustainable Development Goals because of the problem that arises due to antimicrobial resistance. And you have called upon progressive research and policy actions into looking at the magnitude of the problem, doing monitoring and evaluation, using innovative tools like AI, and also you have called upon the use of genomics as one of the innovation as well, and you have called upon training and also calling for further funding, including the recent call to NHR, which should generate quite substantial amount of knowledge to continue the fight. The next person I'm going to call is the very person who has made a very huge contribution to this symposium, and that is none other than Dr. Upendo Kibwana, also from MUHAS. Dr. Upendo Kibwana is an academician and researcher at Muhimbili University of Health and Allied Sciences in the Department of Microbiology and Immunology. She's the lead of ROCKET, the project in Tanzania, and a multi-country initiative aiming at strengthening regional and national capacities to prevent and respond to antimicrobial resistance through the One Health approach that we are really advocating today. Dr. Kibwana has over 10 years experience, has published many articles around antimicrobial resistance, including evidence about multi-drug resistance bacterial pathogens in different hospital settings. She's very dedicated and one of the key people who will help us to fight against antimicrobial resistance. So let us clap our hands as she comes forward to give her keynote speech. Welcome, Dr. Kibwana.
Thank you, Professor Sangeda, for that introduction. Good afternoon, ladies and gentlemen. I see a lot of yawning. People are tired. But there's a common phrase, tule mtori nyama ziko chini. So please, we are almost there. We are almost getting nyamas. 15 minutes or so, very brief, to tell you what rocket is, so that you don't say these days it is into aerospace engineering. It is not rocket. So very brief, so that we really get time to do the panel discussions. So this rocket, it's an acronym, a French acronym for the partner countries. Uganda, it's not spelled Uganda in French. Ethiopia, Tanzania, and Kenya. That's why we came up with rocket. It's a 2 years project. We started it in 2024 in August. And as the chairperson introduces, the main objective was to strengthen the fight and our capacities to respond to the scourge of antimicrobial resistance through the One Health approach. We've been talking One Health, but in reality, for so many years, we've been working in silos. So this was a multi-country initiative, and it was supported by the French embassy. So in implementing this project, the previous speaker said most of our research are donor-oriented. But in doing so, you have to be keen. So in Rocket, we took keen of the National Action Plan, the second one that we are dealing with the 6 objectives, and we dwelt on the 2 objectives, the second and the fourth one, being improving AMR awareness, communication and education, and the 4th objectives. So as a country, we had our components, because this, as I said, it was a regional consortium. So we had our 2 objectives, which we have implemented very well. And in Tanzania, we implemented our objective across different regions, including Dar es Salaam, Kilimanjaro, and the rest. So we could not do this on our own. We had different stakeholders. You cannot do it as MUHAS, or I cannot do it as Upendo. So we engaged different stakeholders, including the Ministry of Health, the Ministry of Livestock. We had the MCC members who are also here, some technical working groups, universities, healthcare workers, and other implementing partners. So in our activities, we were around 6 or 7. We had to review the undergraduate curriculum on AMR-related issues, and in a very short while, we'll see why. We also developed some new SOPs and reviewed some of the existing ones in terms of testing pathogens of high priority, and also we provided some supportive mentorship to some of the selected sites. We also did some training workshop, and as a teaching university, our work is dissemination. So we did dissemination of the best practices in the first year of the project, and what we are doing now is also dissemination. So the expected outcomes was that we should develop at the end of this project some integrated antimicrobial stewardship curriculum for in-service healthcare workers, also to have some laboratories which have gone from one level to the next, integrating them into the national EQA program that is offered by the National Public Health Lab. And also we had a role of coming now with recommendation, where from our panel discussion here, some of the recommendations we'll get from these activities. So our first activities was to identify the gaps. I know some of us will say, do we really have the gaps in our curricula? Yes, we do. You'll be surprised by the data that we got. And here the issue was not really that we are not teaching AMR-related curriculum. Take a classroom, Professor Mloka there is teaching, vis-a-vis the one which Dr. Lillian is teaching on AMR, they will be different. Professor Mloka has a passion on antimicrobial resistance. That's her area of competence, but Dr. Lillian is into immunology. Now what guides them? It's about the curriculum. If not documented, it's not done. So do we have a blueprint? When it comes in first year or in second year, what we supposed to teach them? So that's why we ventured into this, and this is the approach that we used. We used some tools that are developed by WHO, but of course we had to adopt them, and then we had different stakeholders, and the stakeholders here are the universities, obviously. So this is what we find. There are some areas which we are really good, but there are some areas that we are still really lagging behind. As I say, the issue is not that we do not teach them, but who directs you? Who dictates you to do that? Is your curriculum very vocal on that, or is it just silent? So we find most of the things were really silent, and this is something that we have to think about it. So one of the examples, one of the issues, the waste management in healthcare facilities. I will tell you honestly, it was during that time I found out that we are supposed to return the antibiotics that we use if we've not finished them. But I'm here, I've been teaching for more than 10 years. That's when I find out that. But where was I to get that information? These experts, undergraduate, they are the people who are the champions, they are the pioneers, they are the power of information when they go out there. So people are expecting them, the communities, they're expecting them to know everything. When ni daktari, unajua, sindio? So whatever they tell them, whatever they feed the communities, that's what they get. And very unfortunately, for us who are literate or experts, we don't speak. Those are not our issues. I'm not a social media person. Sindio? We're all aware of social medias. A wrong message can really go viral. So we really have to empower these. These things are silent, so it's high time that we resolve this. But then we had an opportunity. Yes, there are some, the undergraduate will capture them in a larger group, but what if when they exit, all those who have already exited, what about them? So we also formulated and integrated a stewardship short course curriculum, and I encourage all of you, we are currently liaising with professional bodies so that you get CPD points to this. So sometime later this year, we'll advertise it in our website, so we encourage all of you to participate on this. It's going to be a 1 week program with 5 modules, and in each week we'll have a different module. There's nothing as I know too much. They say knowledge room, or the biggest room in the world is the room of knowledge. So please, I encourage all of you to do so. And then, as I say, there are some SOPs, and they were there, but they need reviews. Science is not static, it's dynamic, so things change. So we did develop some new SOPs, and the ones which were already there, we did some revision, but we did not stop there. We did dissemination. And this is the problem with many projects. So we do a lot of things, but do we disseminate, and to whom do we disseminate? So we made sure that whatever information that we had, we went down to the end users. And they were also part in making the new ones. So we also done some mentorship visit. The National Public Health Laboratories has a proficient testing scheme which is free in all the countries, and for microbiology labs which have the capacity to do culture and sensitivity, they're enrolled in this scheme. So we went there and we look at we took 12 laboratories, and the criteria was those which you are not performing so much and also those which you are performing. So mentorship does not end with poor performance. Even those who are performing well, you have to mentor them, you have to nurture them. So it always stayed like that. And the keynote thing or a strike thing that I want you to notice that there was one of a lab, RRH, these were regional referral hospitals, and then we had some regional hospitals and just other healthcare facilities. So we had one regional hospital. So their results before the site mentorship, their performance was 58%, but after our site mentorship, the next score was 70%. There could be other confounding factors, but we cannot left out. Perhaps it's because what we did, because we really did site mentorship visit, we sat with them, show them step by step, and to be surprised, people do not know what you know or what you think that they know. So another thing that we did, we capacitated the Central Veterinary Laboratory to make their own proficient testing materials, just like what NPHL is doing for the human sites, so as to monitor the quality across the veterinary laboratories. And we have sent these samples to four sick laboratories, Arusha, Mwanza, Mtwara, Dodoma, and we are waiting for the results as we are speaking. So what has this project really done? Is it just another project or what? So we've done some capacity building. As I've said, we've done some mentorship to 12 laboratories, and 10 of them show an improvement into their results. But also we've empowered these health facilities in identifying and testing priority pathogens. And as I've said, we have developed the integrated stewardship and microbial short course, which will help us in sustainable training. While you're doing something or while you're implementing a project, challenges are always there. So we found some challenges. So there is an issue of loss in translation. So we know that the SOPs, you are here thinking now, right now, I'm not going to start all over, but to find that people don't know. As I said, the issue of dissemination, whom are you disseminating? Where does the data goes to? And then there's an equal triad. We've been saying one health, one health, one health. But really, are we moving in the same pace? I will admit, even in this project, environmental sector was somehow left out. So you see, that's a problem. And then there's an issue of staff reallocation. You train, and this is really a problem. You're going in a site, these surveillance sites, you find there are people who were well trained on what to do, go there 4 months, 6 months later. We know people go for green pasture, it's a good thing. People go for training to enhance their careers. But then it's like you're moving a step back. And then the issue of coordination among implementing partners. I'm doing the same thing, that is doing the same thing or even different, but how do you go about it? And then the issue of funds, internal funds. While we are doing the EQA or the site mentorship supervision, the lower scores not necessarily means that they don't know, but they don't have reagents or what to perform the test. So somebody is knowing that I should do this, but then I don't have reagents. There are no funds. So what should be done? Even if you teach them, and you know, learning in primary, we're told seeing is knowing, remembering, but practice, it makes it perfect. So there are no reagents, there are no equipments. Even the knowledge that you have transmitted to them, and at the end of the day, it doesn't become sufficient. So what do we think will be done, or what's the way forward? So I think it's high time we move from the field to life. We are here, we are gathering, we'll have journals, I'll use the journals maybe to exceed in my career, but then how does it help? It's high time we think about getting this data into the right hands. Whatever you're doing, get them to the actual end user. And then it's high time we also start thinking about shifting the front lines, stabilizing the healthcare workforce. Oftentimes we like workshop. You call a few people, and after workshop you tell them, please go disseminate, but does it really work? I think it's high time we start going to the source rather than calling them. And then perhaps we should start reinventing the wheel. We should always build up on what we have and not start over. Today it's rocket, I'm doing this, and then tomorrow another project comes, and then it's like the start over. It's duplication of efforts. And then now this, I think, and I'm hoping among the members of the MCC or representative from the government, they will help us to answer the sustainability gap. How are we moving from here? It's something that we've been talking. And with that, I end my presentation. This is a group photo for our end of year 1 dissemination. So next time I present rocket project, I ask for your consent to use a group picture that we've shared today. And I like to acknowledge, of course, the main donor, the Republic of France, through the French Embassy. We have worked closely with the Ministry of Health, the Ministry of Livestock, MUHAS, and in MUHAS worked with faculty from microbiology department and pharmaceutical or microbiology, but most importantly, we also worked with the healthcare workers from the participating sites, and without forgetting the National Health Public Laboratory. They made this possible. Thank you.
Thank you so much, Dr. Kibwana. I'm sure now people, they know how to pronounce rocket, because some of them were reading it like roho ket. And if you look at it internally, yeah, indeed it is, because roho is a spirit, and in the spirit of what Professor Mateo was discussing here, you could immediately see that Dr. Kibwana and her collaborative team have already started working on the issues that Professor Mateo had highlighted as issues requiring integrated approach to combat antimicrobial resistance. So congratulations, Dr. Kibwana, for that kind of talk. Amazing talk. Amazing talk. So you have covered some of the issues, including the sustainability of funding, issues of capacity building, and making sure that we continue this. So we will now move on to the next session. And the next session is going to be a panel discussion. And we have quite a number of renowned panelists. I'm going to introduce them as they come forward one by one. After I read the profile of the panelists, they will come forward. Then we'll have a set of discussion questions to lead our discussion. For the sake of time, we might reduce the number of questions, so we may have a session for question and answers at the end. And Dr. Kibwana, do we have all the panelists? Okay. So I'm going to introduce them one by one. And for the sake of time, these are very prominent people with very huge bios, and I'm not going to read all of it. Just suffices to say these are very renowned people, and they are here because of that. So I'm going to start with our very own Professor Jeremiah Seni. And as he comes forward, please clap for him. Professor Jeremiah Seni is a professor of microbiology and infectious disease. At Catholic University of Health and Allied Sciences, KUHAS. He's also the Director of Research and Innovation at KUHAS, a registered medical specialist at Bugando Medical Center in Mwanza, Tanzania. He's also the National Chairperson of the Antimicrobial Stewardship Technical Working Group, which is also a member of the National Multisectoral Coordinating Committee, as you have heard from the guest of honor. And he's a member of the National One Health Technical Working Group and a member of the National Biosafety and Biosecurity Technical Working Group. He's the co-chair of Regional Antimicrobial Resistance and IPC Communities of Practices under the East, Central, and Southern Africa Health Community. So he has quite experience in clinical research and leadership in several fields, and he has published many, many articles, hundreds of articles related to the topic we are discussing today. So he's here and he's going to share his experience. So once again, let's give him a hand of applause. The next person is Ms. Mwanaisha Mrisho. Please, let's give a hand of applause to Mwanaisha Mrisho as she comes forward. She's a public health specialist with over 3 years of experience in public health surveillance, preparedness and response, health systems management, health monitoring and evaluations, and she's currently working with the Prime Minister's Office on issues of police, parliament coordination, and persons with a disability. So as you can see, these are very key issues. And as you know, there is also a parliamentary committee which looks at antimicrobial resistance. I'm sure she's a very good link to that parliamentary coordination. And so she also works with the Directorate of Disaster Management in the Department of One Health. And she does a lot of other things for which we link her to today's talk. The next panelist is Dr. Joseph Malakalinga. Yes, let's give a hand of applause for Dr. Joseph Malakalinga. So Dr. Joseph Malakalinga is a senior quality assurance officer who works with the microbiology, molecular biology, biotechnology at the Tanzania Bureau of Standards, TBS. He plays a key role in strengthening food safety and quality assurance in laboratory-based surveillance systems. He has extensive surveillance expertise working in food microbiology, especially for foodborne pathogens. And therefore, he's going to be very useful in the discussions that we have today. So again, let us clap for our panelists. The next person is Dr. Matthew Mganga. Dr. Matthew Mganga, yes. Please let us give him a hand of applause. Dr. Matthew Mganga is a senior registered pharmacist, a health supply chain specialist with over 18 years experience in Tanzania health sector. He is a focal person in the national coordination of the bottom-up quantification at the Prime Minister's Office, Regional Administration and Local Government, TAMISEMI, and where he oversees the logistic management system, managing about 8,000 facilities in Tanzania. So he carries with him a heavy experience. He's a PhD from University of Dodoma and a very proud alumni of MUHAS, where he did his master's in supply chain, I believe, but also he's done some ABA from Mzumbe. So he has quite some experience on the issues of antimicrobial resistance. And the next person is Dr. Sharon Ismail. Let's give a hand of applause for Dr. Sharon. So Dr. Sharon is internal medicine specialist in the infectious disease unit at the Muhimbili National Hospital. He's the leading member of the MNH Antimicrobial Stewardship AMS Committee. And you will agree with me from her experience that she's a very pivotal person in institutionalizing antimicrobial stewardship interventions by conducting some quarterly PPS studies for antibiotic utilization at the hospital. So let's again give her a hand of applause. The next speaker is Dr. Elasto Mayenga. Please welcome Dr. Elasto. He is one of the veterinary... Emmanuel. Sorry. Dr. Emmanuel is on the veterinary front line, and he works with the Tanzania veterinary laboratory agents, and he's going to address some of the hidden challenges of unregulated veterinary dispensing and how we can incentivize the livestock keepers to reduce the prophylactic reliance. So we are going to hear from this talk, and for the sake of time, we'll see how much of the questions we have. I have 2 questions for each of the speakers, the panelists, but if time will not allow us, then I might skip some of the questions or even add some questions if it adds quite interesting part to the audience. So, to open our talk, are you ready? Yes. Are you ready? Yes. Really? Yes. Okay, good. So, perhaps we can just divide them as thematic areas, and the first one is on antimicrobial resistance and use. And I'll go straight to Professor Sen with the question on, and he can tell us how can Tanzania better reconcile the dual challenge of ensuring universal access, which is a key issue that the country is trying to achieve, to these essential antibiotics. But simultaneously, we are again trying to control the widespread of irrational use of the same molecules because of their over-the-counter availability of these medicines. So again, it becomes like a dual challenge. Perhaps you can tell us briefly as a starting point for our discussion. Please welcome, Prof.
Thank you very much. So thank you very much, Professor Sangela, for that question. Striking a balance between do we have, for example, machinery or policy guidelines which can help us to make sure that we push for the access, we minimize the excess, and at the same time we really counteract the misuse of antimicrobials? So the answer to this would be yes. Looking at the global level, we have the WHO Essential Medicine List, we have the WHO Access Watch and Reserve categorization of antibiotic book, which was published in 2023. And if you look at these 2 documents, they clearly stipulate the issue for access. And they are pushing of all the antimicrobials that we have, actually the access group should actually constitute more than 60%. And the 2024 United Nations General Assembly in New York, I think the heads of states also deliberated that the access to antimicrobials should be also something to be capitalized. And actually for the UN General Assembly, they even rose the bar. So it was not only 60%. So for for the